We think this is the second edition. Last month we had the first edition, and during the first edition, we had one of the best presentation. I, in particular, I viewed it as one of the best introduction lectures that ever, took part. And so today we decided to recall back Professor Ashok Rattan to come and speak to us on advances in COVID-19 treatment. I think during the last presentation, as I said, Professor Ashok was quite amazing because some of the data he put last month was quite amazing. So we hand over to Professor Ashok to present today's global lecture. Over to you, Prof.
Thank you. Thank you very much. Let me just put up my slides.
Yeah.
You have to enable screen sharing.
Screen sharing, okay. Yeah. I've done it.
Yeah.
Yeah. The volume.
We would focus on oral antivirals for treatment of COVID-19. I have based my submission on available literature as well as the submission made to US FDA by Pfizer and Merck to gain emergency use authorization. The NIH website indicates that after testing many of the drugs that were being repurposed for COVID, they found that monoclonal antibodies decreased the risk reduction by 85%. The first oral antiviral was Paxlovid, which is from Pfizer, and it decreased the risk reduction by 89%. And the second one is Molnupiravir, which reduced the risk reduction by 30%. This was, of course, before Omicron made its way in the public life. Then Remdesivir, which is IV, was reintroduced, as well as they found that Omicron was resistant to most of the cocktail monoclonal antibodies which were available, except for Sotrovimab. But the sublineage BA2, which seems to be predominant in some places like India, that is resistant to Sotrovimab. And luckily, recently, US FDA has approved a new monoclonal antibody, Bebtelovimab, which is active against BA2 subvariant of Omicron. But Remdesivir and the monoclonals are injectables, and we will not talk any more about them. It is about Paxlovid as well as Molnupiravir, which we will talk some more. Now, the first oral antiviral, which was approved by US FDA, is a combination of two protease inhibitors. One protease inhibitor, which is new and specific for COVID or SARS-CoV-2, is Nirmatrelvir, which is available as 150 milligrams, and it is combined with Retnovir, which we already had available for anti-HIV activity. Both of them are protease inhibitor, but while nirmatrelvir is active against protease inhibitor of SARS-CoV-2, Retnovir has another function, which I'll explain. Now, as I said, both of them are protease inhibitors. Protease are like scissors. And if we recall, SARS-CoV-2 enters the human cell by attachment of the spike protein to the ACE2 receptors. Once it fuses with the cell membrane, the RNA, it is a single strand RNA of 30,000 base pair that is released, and it is transcribed into one whole length of protein. This protein is then cut by protease into various protein structures of the virus. It is packed and then released. What happens is that this molecule will block the main protease, and it will prevent the action of main protease. It will disable the cutting of the big protein chain which has been made, and therefore the virus will no longer have its component proteins and will no longer be able to produce and cause infection further. Protease, as I said, protease inhibitors, protease is like a scissor, and protease inhibitors will block the action of cutting the long chain protein into capsid protein or RNA-dependent RNA polymerase or integrase. And since these proteins will not be available, the virus will not be able to be assembled, and as a consequence, the viral will no longer multiply. But while the primary drug was effective against the virus, it was metabolized by liver enzymes, which are known as CYP enzymes, and CYP3A4 is an active liver enzyme, P450 enzyme, which will decrease the level that could be reached by the primary protease inhibitor. To block this, scientists at Pfizer used Retnovir, which they already knew was a potent inhibitor of CYP3A4. So while the primary drug would have been metabolized and would not have reached high level if given alone, when it is combined along with 100 milligrams of Retnovir each time, then since it will block both the intestinal as well as liver enzymes, the level will be high. The problem is that since CYP3A4 metabolizes a number of drugs, and since these patients could be taking a number of drugs, there could be possibility of drug-drug interaction. And there are a number of CYP available. Both there are inducer as well as inhibitor of CYP. Inhibitors of CYP are listed here: clarithromycin, indavir, itraconazole, ketoconazole, fluconazole, and even grapefruit juice, verapamil. These are inhibitors of CYP, and the inducers of CYP are rifampicin, carbamazepine, St. John's wort, dexamethasone, phenobarbital. These will then have effect but as a consequence of inhibition by retinol of CYP enzymes, you would expect that, that the drug level of these drugs may be changed. And as a consequence, the physician, when he's using molnupiravir, must keep in mind whether other drugs are available and whether toxicity or suboptimal drug will result. In vitro, nirmatrelvir had good activity against all variants of SARS-CoV-2, and it also had activity against Omicron. And at the same time, while in nanomoles, it will be able to inhibit the in vitro activity in the cells against human target cells, it did not have any toxic effect. So that there was a wide range, wide safety range between the toxicity that would emerge against the virus vis-a-vis human cells. And because retinol would prevent its metabolism, therefore, in phase 1 trial, they found that good levels were reached, and the levels were higher, much higher than the effective concentration 90 against MERS, against SARS-CoV-1, against SARS-CoV-2. So you could postulate from here that for more than 10 hours, the levels of the drug, once given as a combination, would be higher. And so if it is given once in the morning and once in the evening, that means in BID doses, then for 24 hours, you can have effective levels against the growth of the virus. 3 clinical trials had been initiated by Pfizer. One was against evaluation of protease inhibitors for COVID-19 against high-risk group, then against standard risk, and the third was as post-exposure prophylaxis. Only results of the first trial were made available, and that had 3,000 persons. In this, the aim was to take persons who were unvaccinated and were more than 18 years of age and had one high risk high risk condition, which might lead to progression to severe disease. And it was the treatment, oral treatment was started for 5 days. Within 5 days of the RT-PCR result or antigen positive result. This was then followed up for 24 weeks. So treatment was 300 milligrams of nirmatrelvir plus 100 milligrams of retinol given twice daily for 5 days. And then it was followed up for 24 weeks. When you compared the Paxlovid group versus the placebo group, you found that there was no death in the Paxlovid group, and there were 7 deaths in the placebo group. In the final analysis also, there were 9 deaths in the placebo group and no deaths in the treatment group. This indicated that the risk reduction was 89%. The second endpoint was hospitalization. So while there was no deaths, in hospitalization also, in the treatment group, you had 6 out of 607 which were hospitalized. In placebo, you had 41 out of 612. That means the risk reduction, relative risk reduction was 85%. And in the final analysis, 8 were admitted out of 1,039. In the placebo group, 66 were admitted out of 146. a relative risk reduction of 88%. When they looked at the viral load, they found that the viral load reduction was modest, 1 log, that means 10-fold reduction occurred in the persons who were treated. Safety profile was also good. There was nothing to choose between those who received the drug versus the placebo. And overall, their conclusion was that the drug has clean genetic toxicity, overwhelming efficacy. Final analysis in high-risk group was very good. Largest comprehensive development program for an oral COVID-19 antiviral across 3 patient population has been tried. 1 results have been shared. Manageable drug-to-drug interaction, though the possibility of more interaction exists, especially when it is given to a larger group of persons, especially the elderly. And it showed in vitro activity against all current variants of concern, and real-world evidence would indicate whether it is still working or not. Unfortunately, this has not been, emergency licensing has not yet been given, so it is available only through Pfizer and available in limited countries only. On the other hand, the Merck had another approach. Instead of looking at protease inhibitor, they looked at a ribosome nucleoside analog, which would then mimic uracil or cytosine and will get incorporated into ribosomal dependent RNA dependent RNA polymerase, which will then, once it is incorporated into RDRP, it will lead to mutations and then subsequent death of the virus. So the virus would not be able to replicate well if RDRP is damaged and mutations have occurred in that. You would appreciate from your previous information that COVID infection or disease could be divided into 3 phases. The first phase was viral phase, second phase is the pulmonary phase, and finally it is the inflammatory phase. Since virus is present in the first phase, first 5 days or so, or first week or so, it is essential that antivirals, if they have to play any role, it must be given as soon as possible and in the first 5 days only. If antivirals are given subsequently, they would have no effect on the course of illness. So the second drug, molnupiravir, is, as I said, a prodrug. It is it's a nucleoside analog which will mimic cytosine or uracil. And once it is incorporated into the RDRP, it will cause mutations. This is again reiterating that the target for oral antivirals are only mild and moderate OPD patients. Mild and moderate OPD patients in which antivirals are indicated, and they must be started within 5 days of appearance of the symptoms. It is claimed by Merck that molnupiravir addresses a critical unmet medical need. It's an oral drug. In phase 3 clinical trial, when they looked at hospitalization or death, they found that 28 out of 385 persons on molnupiravir were hospitalized, while in placebo, it was nearly double of that. So there seemed to be a significant advantage in taking molnupiravir. It was the intention of molnupiravir is to treat mild to moderate COVID-19 in adults with positive results of direct SARS-CoV-2 viral testing, and those who have high risk of progression to severe COVID-19, including hospitalization or death. The dosage here was 800 milligrams. It's available as 200 milligram capsules. Four capsules in the morning, 4 capsules in the evening for 5 days. No dose adjustment was required in patients with renal or hepatic impairment, and no drug-to-drug interaction were identified as opposed to Paxlovid. This can be taken with or without food. Treatment should be initiated within 5 days of starting the symptoms. Molnupiravir is a prodrug. It is rapidly converted into N-hydroxycytidine, and then this is then incorporated as phosphorylated triphosphate, and then this will be incorporated into RDRP, and this RDRP will then be mutated. So the viral sequence does not stop at once, but with 1 or 2 additions, there will be mutations, and consequently, there's transactional errors, and the viral will no longer be able to repair itself, and the virus will die. The viral load decreased. It had activity against alpha, beta, gamma, delta, as well as Omicron, and there was significant decrease in viral titers. They also noticed that it had, it is active against SARS-CoV-1, SARS-CoV-2, as well as MERS-CoV, and it will lead to decrease in viral load as time goes by. This was active both in vitro and in animal models. And as the mechanism of action is to cause changes in RDRP, so that RDRP is mutated, and so it cannot function. And here also they notice that mutations occur on molnupiravir in RDRP. And there were, no amount of spike substitution had any effect on the activity of molnupiravir, so it will be active against all types of variants of concern. Molnupiravir, as I had already indicated, that it will cause changes in the nucleotide incorporated into RDRP, and therefore it will prevent the progression of the viral multiplication. There was a little bit of concern about its non-human toxicology, and so a lot of work has been done on non-human toxicology, especially when in one of the experiments, the non-clinical safety topics that they've covered is genotoxicity, hemopoietic findings in dogs only, growth plate findings in rapid growing rats, and embryo fetal lethality and teratogenicity in rats. They found that when you use bacterial mutagenicity test, which is known as Ames test, the test was positive, but in vitro mammalian cells, it was negative. And also in Chinese hamster ovary cells, there was in vitro signal followed up in vivo, and it was said to be negative. So ultimately, they concluded that after doing regulatory GLP, good laboratory practice in vivo genotoxicity assessment, they found that this did not have genotoxicity, though in vitro genotoxicity was positive. So based on totality of data, molnupiravir has low risk of genotoxicity in vivo. In the hemopoietic finding, they found that the findings were restricted only to dogs, and the findings that they found were not reflected in human beings. There was increased growth plate thickness in rats, but again, this has no implication in human beings. There was assessment of development and reproductive toxicity, and since they found changes here, it has been suggested that molnupiravir should not be given to children and should not be given to pregnant women, pregnant or lactating women. So the summary was the non-clinical safety profile supports the proposed short-term use of molnupiravir for the treatment of mild to moderate COVID-19 in adults. It was seen that if you give 5 days of this drug, morning and evening, by the 4th day, the upper respiratory tract becomes sterile for the presence of viruses. A number of phase 2 and phase 3 trials have been done, and each one of them have shown that it is effective in preventing the transition from mild to moderate to severe. The pharmacokinetics also indicated that good levels are reached in the blood and the levels are effective against the virus. The phase 1 study indicated that exposure increases dose proportionally, then limited accumulation occurs after 12 hours, after BID dosing. The effective half-life was 3.3 hours, limited renal elimination. There was no meaningful effect of food on PK, so it can be taken with or on with food or on empty stomach. And it had good over 5 days. You would find that at least 3 log, that means 30 times, is the decrease in the concentration of the virus. And this was best if you give 800 milligrams BID. So that's why 800 milligrams was the dose which was the final dose chosen. Every time when you, this needs to be given as soon as possible and for 5 days. The sooner you start, the better it is. But whenever you do the analysis, you find that persons with molnupiravir perform better. So finally, when they went to phase 3, and since they had the concern about mutagenicity, the studies were done in non-hospitalized adults with mild or moderate COVID, and patient population were at risk, and they were stratified, given 800 milligram BID. First was efficacy. They found that efficacy was to look at death on day 29 after 5 days of treatment, and they found that it was effective against most modern clades of variants of concern, including alpha, delta, gamma, mu, as well as lambda. The effectiveness was that 28 out of 385 needed to be hospitalized, vis-a-vis against 53 out of 377. So there was a 6.8% point reduction. They have not mentioned the same way as a relative reduction, risk reduction, as Pfizer had mentioned. But as you notice, at least half of the patient, less than half of the patients progressed on to severe infection. And this hospitalization and death, the advantage was seen in both on molnupiravir when compared to placebo, indicating that the patients were at risk if they were not treated with molnupiravir, and once they are given with molnupiravir, death and hospitalization would be prevented. The clinical efficacy was reduces the risk of hospitalization or death through day 29. 9 out of 10 deaths through day 29 occurred in the placebo group. Molnupiravir was associated with improved clinical outcomes based on self-reported COVID-19 signs and symptoms. And virological response was associated with lower mean SARS-CoV-2 RNA at day 3 and day 5, and reduces percentage of participants with infectious virus compared with placebo, and leads to increase in viral substitution consistent with proposed mechanism of action. The side effects were non-significant, and safety profile for 5 days course was nothing to comment about. And except for the mutagenic potential, there was nothing else which was negative as far as molnupiravir was concerned. And so the caution is that it should not be given to persons who are pregnant or likely to become pregnant, because we do not know whether the mutagenic potential will translate into human mutations also or not. And but otherwise, in adults and in it's not safe in children. The safety in children has not been established. Safety in pregnancy has not been established. But otherwise, it should be all right for adults and those with chances of progression to severe infection. So treatment of mild to moderate coronavirus disease in adults with positive results on direct SARS-CoV-2 testing and who are at high risk of progression to severe COVID-19, including hospitalization or death, is what it is intended for. So comparing the two together, these are the features. You'd find that both Paxlovid, which is not available widely, while Molnupiravir, Merck has given emergency licensing to many pharmaceutical companies in developing countries. In India, at least 13 of them have started manufacturing, and Molnupiravir is widely available and is cheap, it's effective, and it could be useful in making sure that the virus is cleared from the upper respiratory tract. I thank you for your attention.
Thank you very much, Professor Ashok. With this, based on our experience from the last time, what we've decided is for each lecture, we invite one person, one expert, then we exhaust the topic at stake. So today, Professor Ashok is the only speaker. So if anybody has any question, the person can unmute himself or herself and ask a question. Prof. Ashok, I think I have a couple of questions. So the first one has to. Okay, Samuel. Yeah, Samuel, you can ask.
So, Abubakar, please ask. Then I will do at least.
Okay. Okay. So, Prof, the first question with me has to do with the inflammatory responses. What I'm thinking of, is it possible? I don't know whether they've done that kind of research or clinical trials. Is it possible that maybe we add during our, strategy of having a proper management strategy, if maybe we look at adding Molnu to any inflammatory drug like indomethacin, I don't know whether it will help in managing the patient properly, those with the advanced or critical COVID-19.
See, it's been mostly mild and moderate that they have tried the oral drugs. And once a person, of course, there was that study from Yale University, which tried to find out why some persons died and others survived. And they came up with the theory that those persons who had neutralizing antibodies by day 14, they would survive. And those who did not have neutralizing antibodies by day 14 would ultimately die. After that, the monoclonal antibodies came, and you found that monoclonal antibodies, when they were used with the president, then president of US, cured him very quickly. And the mutations then took place. So instead of one monoclonal cocktail had to be used. Now with Omicron, again, as I've indicated, monoclonals may not be working. So in mild cases, any of these two drugs would work. And molnupiravir, I think, is available, commercially available in various parts of the country. I think the only concern is about its toxicity from the mutation point of view, and so it should not be given to the pregnant ladies. But with ivermectin, I was not sure whether it is, there have been too many sites being taken with ivermectin. So I don't know what to comment on that.
Okay. Yeah, Samuel, I'll come to you. I have another question. On the same molnupiravir, I think from the data that we have, is it 4 capsules per day?
Yes.
Yeah.
4 in the morning, 4 in the evening. So
yeah, 4 in the morning, 4 in the evening. Don't you think? Don't you think it will play a part in this issue of adherence? Because maybe somebody taking a whole lot of 4 capsules, I think it's a bit a lot, isn't it?
They tried with 200, 400, and 800, and they found that the effectivity was best. And so I think it's available in India for 1500, the whole 40 capsules. So because 4 in the morning, 4 in the evening for 5 days.
Okay. I was thinking maybe if they will come out with something very ideal, maybe doing it 800 milligrams, 1 in the morning, 1 in the evening.
See, that becomes too large. You have to have capsules which could, because the drug itself will have some incipients to keep it stable. So that then to swallow becomes difficult.
Yeah, okay. Then my last question before going to Samuel is from the data, I think they say it's either short term. It's taken for a short term. I'm still talking about the molnu.
Yeah.
Yeah. So my fear or my concern from here is the prospect of in the long term, maybe the emergence of resistant strains, which are
in the short term, it didn't appear, but and within 4 days' time, all the viruses got removed. I think the implication it will have is that some of these drugs also work on Ebola.
Okay.
So that it's not, one is of course SARS, but now that it's shown, it's known to work on SARS, and it has effectivity on MERS. It also has some activity, or they can tweak it, because one thing I forgot to mention was that these drugs are effective against RNA viruses and not against DNA viruses.
Oh, okay.
So that, and RNA viruses do cause a lot of problem, and it may be possible that more of this, if RDRP is working, then that may be a target for even influenza.
Okay, Samuel, yeah, okay.
So that offers new possibilities of new targets being discovered. And as you notice that in the recent part, HCV can be eradicated now. It can be cured.
Yeah.
So that's very few viruses that we can really cure infection. And HCV is one of them. Coronavirus seems to be the second one, which can be cured.
Okay, Samuel.
Yeah, thanks.
Samuel, can you help us maybe put on your video so that we see your face? Yeah.
Okay, thank you. Thank you. Can you see me now?
No, I can just see your camera, but you ask your question.
I don't know. It's not showing me my face. I don't know
Yeah, it's
why.
not sure. Yeah, so you ask your question. You ask.
But the lights are on. Okay. What I wanted to ask are two. We all know during this period, people tend to take juices and all these things. In the initial slides, you said grape juice and others tend to interfere. And we all know people take grape juice to improve immune response, or how elaborate, to improve the immune system. So at what point do you start such treatment? And also for the case of the mutagenic, at what point do you start monitoring, or which category of patients are at high risk of such mutagenic potential? Thank you.
Mutagenic potential, mutagenic potential, you would now, normally it's the pregnant ladies that you don't want to take a chance. What happens is that there's a lot of preclinical study done on animals. The aim is to find out, and they give very high doses. Say, if the effective dose is 1 milligram, they would give 40 milligrams, 400 milligrams, to see where is the toxicity. So the aim is to study the toxicity in animals and then see whether this occurs in human beings or not. You might know the story about fluoroquinolones. As you know, that when fluoroquinolones were being discovered, they noticed that it affected the growing cartilage of beagle dogs. And as a consequence, they said that fluoroquinolones should not be given to growing children, because otherwise it will cause damage to the cartilage of weight-bearing joints. And but in 1990 there was an outbreak in India of Salmonella typhi, which causes typhoid, which was resistant to chloramphenicol, to Septrin, to sulfa, and to amikacin. So all the 4 drugs which are used for the treatment of typhoid was resistant, and only ciproflox was sensitive. At that time, the clinicians had to take a choice of whether they wanted a crippled child or a dead child. And so they said that even if it causes damage to the cartilage, let us give to the children. And they found that in human beings, it did not cause any damage. So though the warning is there, I think if you see the kit inserts of or product insert of ciproflox, they would be mentioned somewhere that in animals it causes weight-bearing cartilage, damage to weight-bearing cartilage, so it should not be given in children. But when they gave it in children, it was life-saving. So all the toxicity that you see in animals need not necessarily reproduce in human beings, but they are supposed to serve as warning signals that you look for toxicity in at least 2 species in animals, and then trying to see whether the same toxicities are there at much lower dose, because we would use only efficacy dose, and toxicity dose will be much higher. But the aim is to see whether the toxicity occurs or not. Since this is an urgent condition and they have not had time to really let the whole study conclude, they have at the moment given warning that don't give it to children, don't give it to pregnant ladies, but adults and those with high risk of progressing to severe COVID, they would benefit by taking molnupiravir.
Thank you very much, Prof. I also want to ask, you mentioned earlier on, you mentioned in your presentation that I think within five days or so, must they be treated 5 days, or the treatment is for 5 days?
Yes.
You said for better outcome.
Yes, because it is because in this viral infection, the virus is present for the first week. So the aim is that The moment you get RT-PCR positive or a rapid test positive, you should start treatment. Then do not delay in that. That would mean that before you get the test done, you should have decided that if I become positive, should I take the drug or not? And otherwise, if you wait for too long, if you wait for 2-3 days, then it may not be effective. Because what happens is that first there is the viral stage. Then depending upon your response, it will go on to the pulmonary stage. Again, depending upon whether you produce neutralizing antibodies or T cells, then which are able to take care of the virus and the inflammatory response, then you would recover or go into the cytokine storm stage. So if it is cytokine, at that stage, these oral antivirals will have no effect. Oral antivirals are effective in the first week itself.
Sorry, I don't want to monopolize the discussion. Why I'm asking here is, we know testing in this part of I work in Liberia, and I know in some Africa or also we have poor testing procedures, or many people only go for testing when probably when they intend traveling. So most of the cases are from travelers, not within the community. So at that point, probably the person has passed the initial first week or so of infection. So that's why I actually asked. So
yeah,
for that,
if a person is asymptomatic, then maybe he would not take any antivirals, because no drug is without side effects. So if you are asymptomatic or just having a common cold-like symptoms, you are not really that worried. It's only when you know that if this progresses into moderate to severe COVID and you could be in trouble, then you would like to prevent that kind of stuff. So the choice is there. That would mean that if you are not feeling well, then you would consider taking the oral antivirals. Otherwise, there's no point in taking it if you are asymptomatic or healthy. Recently, I came across a friend of mine who was positive for 21 days, but he had a liver transplant. So, and he wanted to travel from Hyderabad to USA. For that, he has to produce a negative report, and he was not clearing. So he kept postponing his flight. I did suggest to him that he could take molnupiravir, but his liver transplant surgeon advised against him. Then after 28 days, he became RT-PCR negative, so he could fly off. So I guess it is, it may not, of course, why I was suggesting was that the virus was present even after 21 days, since he had low immunity. Normally, virus is present in the first 8 days. So after 8 days, the virus cannot be cultured from persons. But when a person is immunocompromised, then sometimes the virus can persist. So it could be, we have to see from case to case what is the situation. But normally, unless you are symptomatic, you would try to avoid taking the drugs.
Okay. Any question? Okay, Prof. When we take, like, for example, malaria prophylaxis, for example, somebody from the United Kingdom going to, let's say, India or somewhere in Nigeria or Sierra Leone, normally the person is given a prophylaxis of for malaria. And as now we are coming out, the world is now coming out, because you remember the last time during the first lecture, I did ask you that question: when should the world be brave enough to start coming out? And I think, like some miracle, they've started listening to us. So the world is now coming out. Do you think it will be appropriate if maybe as part of our strategy, again, we know COVID-19 is here to stay. If you look at issues like influenza and other things, do you think there should be a suggestion that if somebody is going to a high-risk environment, that person can be given maybe Molnu as a prophylaxis?
At the moment, they're looking at post-exposure prophylaxis.
Okay.
Because if the virus is not there in the throat, to take antiviral would not be of any use. But that would mean that suppose you're traveling from America, I don't know whether America is a safe place now. From, but suppose
Yeah.
maybe just to be politically correct,
Yeah.
if you are moving from a low incidence place to a high incidence place, it may be worthwhile to carry one dose of one course of antivirals with you, so that in case you consider that you have acquired while you are in a new place, provided you have any risk factor. If you are young, you are healthy, you're not having diabetes, you're not having hypertension, then you don't have to worry. But most of us have either acquired weight or have acquired diabetes or have hypertension. In that case, yes, we need to be careful. And this is one more armament to the treatment of COVID.
Monu, does it? I don't know whether they've also tried, but I don't know whether you have some view on it. Whether somebody, you just mentioned maybe diabetes, hypertension, then all of a sudden the person also have COVID-19.
In those cases, those cases it might become bad. Suppose a person has bronchial asthma, difficulty in breathing as it is, and then he has from nasal infection, it becomes lung infection. In that case, he would have difficulty in breathing, and his oxygen saturation will fall very rapidly. He would benefit by taking antivirals quickly. Of course, initially it used to be the the monoclonal antibodies were also useful, but the amount of monoclonal antibodies have not been. They have to be available at the site where you are, and since they are injectable, that would mean that there is a certain amount of protocol required. But popping a pill is up to you wherever you are, from low incidence to high incidence. It may be worthwhile traveling. It might be worthwhile taking some with you.
So if you take into consideration maybe HIV, now we have a cocktail of drugs. Do we at a point maybe start thinking if COVID-19 or the other coronaviruses, if maybe we start thinking of, because like Molnu is for a short term, maybe we start adding some cocktails, then we start looking at the long-term effect.
I think we'll have to do the risk-benefit analysis again. At this moment, as you know, Omicron has been milder. It has spread very widely. So every member of the family, once a person gets it in the family, the whole family gets the infection. And it has replaced Delta virus. So that means the good point it has done is that it has replaced the more lethal Delta virus, and it has itself come in place, and it is milder. The only concern is what is going on in Hong Kong. It's not clear. There seem to be smoldering infection going on in Hong Kong. And it might be same kind of condition which occurred last year when COVID was decreasing in every place except for Brazil. And then suddenly you found that Brazil has an outbreak, and then India had Delta outbreak, and that was devastating. So I guess we should not lower our guard, but if Omicron has mutated enough and it's lost its virulence, then it's just a common cold. We just treat it as common cold and not unnecessarily bother about it.
Okay.
While if it becomes lethal again, then again we have to, but of course, each one of us has taken at least 3 vaccination doses.
Yeah.
So we have a lot of protection against serious disease.
Okay, before I come back to Prof for his last comment before we go, I think there are 3 announcements. The first one is before we came on board, people have been sending emails about certificates of participation. So I think this part from now onwards we'll be issuing certificate for those who took part. Then the second issue is as the world is now coming out, what we intend doing is, for example, along the line, we can invite Prof. Ashok to Glasgow. Then we'll be having the lectures on site, face to face, and some virtually. Then finally, the next lecture will be possible on 31st March. We'll come out with a title for that lecture. So, Prof. Ashok, thank you for your time. If you have any last comment, or before then, if anybody has any question. No. So, Prof, the last comment before we go.
In March, we should March 24th. That is the day when TB was described.
Okay. Okay.
We should have that on, and there have been a lot of changes in diagnosis and treatment of TB.
Mm-hmm.
So I think maybe a focus back on tuberculosis, and because everybody is now talking about elimination.
Mm-hmm,
it's a very old disease.
Mm-hmm.
It's a very old disease. It's been there since time immemorial.
Mm-hmm.
And now we're talking about elimination. So I think we should also push our shoulder to the wheel and
Mm-hmm.
talk about elimination of tuberculosis.
Okay, then definitely. Then on the 24th March, it will be on tuberculosis. Yeah.
Yes.
So to all of you who had the time to participate, thank you very much for coming. And Prof. Ashok, thank you very much. This is the second time that I'm dragging you deep in the night.